All right, good evening, everybody. I came on camera here right at the start, so you can see there's real human beings behind this. Nothing is automated, no robots here. So thanks for joining us this evening for a talk about dermatology. There's actually two presentations in one this evening. The first is what's new in dermatology. So there's on your CE certificate, you're going to see two classes listed for a total of 1.5 hours of race-approved CE tonight. So I'm going to let people continue to load in here, give them a couple of minutes, and while we're doing that, I'll do the introductions and a little bit of housekeeping to get you settled. First, there is a chat box here. You can see I sent a message out. I can send out to the entire audience, but when you get into the chat box remains private with the organizers and moderators. There will be two people in the chat box tonight in addition to the speaker to help answer your questions. If you have a question about the content, typically we wait until there's a break or till the end to get those answered. So there is also, the speaker tonight will be using the Poll Everywhere app as well. So look for those instructions. They also came to you in the reminder that you got an hour ago for this session. So you can go ahead and engage with that if you'd like. I'll put those instructions in the chat box as well, so you're ready for that. So we get used to using that chat box. If you could, go ahead and put the state that you're from or city, state, or last session that we did earlier today, there were people from Scotland and all over the place. So it's nice to see where everybody is joining us from. Looks like there's some things filtering in there. Fantastic. All right, so my name is Claire. I'm the Senior Director of Operations for Thrive Affordable Vet Care. We do this as a thank you to the veterinary community, and also because we recognize there's not a lot of conferences to go to right now. So everybody needs some CE credit, and what is better than dermatology during derm season? So I hope that you enjoy this tonight. The session earlier today was fantastic, and this is the same speaker that we had earlier today. So let me introduce you to her. Dr. Valerie Fadok she has joined Zoetis in 2016 with the goal of helping veterinarians manage skin diseases with less frustration. Received her DVM from Washington State in 1978, after which she did an internship in small animal medicine and surgery at the West Los Angeles Veterinary Medical Group. A residency in veterinary dermatology followed at the University of Florida College of Veterinary Medicine, and Dr. Fadok became board certified in 1982. She earned her PhD in experimental pathology at the University of Colorado Health Sciences Center in 1991 and has worked on faculty at the University of Tennessee, University of Florida, Texas A&M, and the National Jewish Medical and Research Center. Prior to joining Zoetis, she worked in private specialty practices in Denver and Houston. Equine dermatology has been a special area of interest for most of her career. And Dr. Fadok has lectured internationally, nationally, and locally on subjects related to veterinary skin disease, immunology, and inflammation, and was a dermatology consultant in the Veterinary Information Network, otherwise known as VIN. Recent awards include the ACVD Award for Excellence in 2010 and the Frank Krall Award in 2018. So lots of great information will come from her tonight. This seminar will have the 1.5 hours of CE credit, as I mentioned. That will come to you about an hour after the seminar ends, and that will come to your email. And the email itself is your certificate, so make sure that you save that. A lot of people, what they do is they'll print that as a PDF to save in their records. If for some reason you are not able to see the whole thing tonight and you have or you have any technical difficulties, with that email will also come a link to the recording of the event. So you can do that, or you can see that on thrivevet.com/learning in the next couple of days. So without further ado, I'm going to turn this over to Dr. Fadok. In the chat box will be myself and Dr. Matt Jurickson from Zoetis, and we will be able to answer your questions that you have as things come up, or we'll save them for Dr. Fadok, and she will answer them when she has a break. All right, well, thank you very much, and I'm gonna drop off camera now so we can get to the content.
Great, thank you so much for joining us tonight. I've been doing dermatology for over 40 years, and I'm not going to have my webcam on, but sometimes it's just nice to put a face to a name. And so this is my COVID look. It's not a great look, but nevertheless, It's really fun to be able to get together with people, if only virtually. So tonight we're going to talk about a couple of new things that I think are very exciting in dermatology that will help us practice better. And then I'm going to go through a series of cases that illustrate how we approach a derm case. And my hope is you'll come away from this with some tips and tricks to help you optimize your use of Apoquel and Cytopoint and get better outcomes with your dermatologic patients. So it's a struggle now to do things in COVID, but of all the specialties that are amenable to curbside or telemedicine, dermatology is one. I mean, skin is on the outside, we can access it. And so I think that some of the things we implement now, such as telemedicine approach, could be brought forward into the future. Certainly with people, they've shown better outcomes when telemedicine is used to help encourage rechecks. So it's something to think about for the future. So we're going to talk about a couple of new things tonight. One is, you're probably aware that Zoetis has come out with Simparica Trio, and this was the type of parasite control medication that I've always called the Holy Grail, and that I hoped for my entire career. We have heartworm preventive, the best flea and tick control you'll ever have with an isoxazoline, and control of zoonotic endoparasites like roundworms and hookworms. And the beautiful thing about Simparica Trio is that you can use this in 8-week-old puppies. So this is a really great way to start a puppy out so that they are protected from a variety of parasites that can have a serious impact on their health. So we know that ectoparasite control is critical for atopic dogs. And our Committee on Allergic Diseases of Animals has recommended that all atopic dogs take a rapidly acting oral year-round. And the reason for this is that we know that fleas are a major flare factor for atopic dogs. And not all of these dogs will necessarily manifest classic flea allergy signs. They will manifest a flare in their atopy. And so, as far as the best orals, isoxazolines are, 21st century ectoparasite control for our pets. And so not only do we get the best flea control we've ever had, but we control ticks. And the added benefit is that isoxazolines will kill anything that crawls on a dog. So I really like starting my workups and managing my atopic dogs with an isoxazoline, because these medications just have given me better control of the atopic state, and I will never miss an occult scabies. So later, I'm going to send a hyperlinks document that will have the links to these treatment guidelines and a number of other things that you might find useful. So one of the things I think that has been most impactful are the studies done in Tampa by Dr. Michael Dryden, and we know him as Dr. Flea, and he's been going to Tampa for years to look at various new products. And since he started working with the isoxazolines, he paired up with Dr. Michael Canfield, who's a dermatologist in Tampa. And what they've been able to show is that using Cereloner or Fluoroner or Afoxaloner, we get not only incredibly rapid flea control, but this is associated with a decrease in itch and inflammation in the atopic dogs in this study. So not all of the dogs in this study are classic flea allergy dogs. A lot of them are atopic dogs with fleas. And by simply implementing really effective flea control, you can decrease their itch and inflammation. Now, it's not enough to make a client happy because their itch level is still above what we consider normal. But imagine the power of coupling this with your Apoquel or your Cytopoint. It just helps these things work better. And here's an example. This is unusual. I'm a serial atopic dog owner, and so I've had 3 Westies and a cattle dog, and now my current project is this little Frenchie, and he's a challenge because he's a severe atopic with food allergy, and he has a number of other problems. But as a dermatologist, he gets everything a dermatologist would do. He's on allergy immunotherapy, and he gets baths, and but in spite of everything I did, and in spite of good compliance with my topical flea control, every fall he would break out with these severe plaque-like pyodermas. They were deep pyodermas, they were painful, and he actually felt sick with them. And this happened every fall. And then I happened to be working with Marielle at the time. I didn't join Zoetis until 2016. And of course, Simparica wasn't around in 2013. So they wanted a video of a cute dog taking NexGard. And I gave my dog NexGard. And an hour later, I found 2 dead fleas on his foot. Now, like most clients, I never saw fleas on my dog. He's a white-coated dog with short white hair. You would think if he had fleas, I would have seen them. And he'd only had his topical the week before. So what this told me is that my topical was not killing the fleas fast enough. And the added benefit is, I switched him to an isoxazoline, and ever since he's been on an isoxazoline, he gets no more of these pyodermas. So what I had attributed to just a bad fall pollen season, it was actually related to the fact that he was getting some flea exposure in spite of topical flea control. And so with isoxazolines, we just do a lot better. And so, one of the things I love that Dr. Michael Dryden says, he says, the best topical ectoparasite control will never be as powerful as the worst isoxazoline. These isoxazolines are amazing. And one of the strategies I use to get better compliance is I don't call it flea control anymore. I call it ectoparasite control. And when I do this, I am able to get better compliance because I can bring in the possibility of occult scabies, or for cats, I can bring in the possibility of Demodex gatoi and convince them to at least do a 3-month trial. And then it's usually easy to get people to stick to it when their pets are doing better. So the other new thing I would love to share with you is some cool new information about Cytopoint. And if I'd had this information when I first started using Cytopoint, it would have changed how I'd used it. And so I'm really happy to have the opportunity to share this with you. So what we knew from our very original studies is that when Cytopoint was given, over 80% of dogs were able to achieve success by 72 hours. A lot of them by 24, but over 80% by 72 hours. But by 4 weeks later, some of those dogs had started to itch again. So that by day 28, we're down to a total efficacy or total success of 69%. So, we know there's a variation in response. Some dogs will go 4 weeks, others go 8 weeks. I have a few that go 12 weeks, some go shorter. And so what we started to hear from our colleagues, though, and these included general practitioners as well as my derm colleagues, is they were finding that when they went to give the second injection or third injection, that the dogs were doing better. They had increased duration of relief, but we couldn't put a number on it. We just knew it was happening. And so one of the questions that comes up, of course, is why is it this variability? Because we know the average half-life in dogs is 16 days, but some dogs will degrade this antibody faster than others. But what we do know, which suggests why a second and third injection might work better, has to do with the pharmacokinetic modeling and the steady state of the antibody in the dog. And so when we give one injection of Cytopoint, we achieve 65% of steady state. Now, I'm not a pharmacologist, and this whole steady state thing, I kind of get it, but to me, I'm making the analogy in my mind of saturation. It's not completely analogous, but I can get my mind around that. And so if I, let's say I have a dog and I represent him as a sponge, when I put my first injection of Cytopoint in there, I'm only getting 65% of the sponge saturated. So there could be IL-31 that's just not being captured after that first dose. But after the second dose, we're better than 90% steady state. And after the third dose, we are definitely at steady state. So this kind of gave the idea, what could we do a study and really measure numbers? What would happen if we took dogs who didn't respond for a full 4 weeks and gave them a second or a third injection? So that's the way this study was designed, and there were over 100 dogs in this study. And so the study design was to give the dogs Cytopoint and then have them come back in 28 days. And so after the first injection, the dogs in this study came back, and 65% of them were actually doing great. So those dogs were considered successes, and their owners were told, you can come back whenever your dog starts itching again. But we have 35% of dogs that are still, that had started to itch again. So those dogs received a second injection, and they were asked to come back in another 28 days. And so after another 4 weeks, we're up to a total success rate of 85%. So simply by giving that second injection, we allowed this subset of dogs to achieve a full 4 weeks of itch relief. Now that still leaves 15% that had started to itch before 4 weeks. So they received a third injection. And what we found is that now we're up to 93% efficacy. So this is kind of changing the way we would recommend that you talk to your clients. Before it was, well, let's give Cytopoint and see what happens, and we'll just kind of see how long your dog takes to respond. Now we want to let our clients know that while over half of dogs will have at least 4 weeks after the first injection, there are some that will not. And it's a good idea to repeat the Cytopoint because we can achieve better success. And if you actually look at the numbers, we can see that we can achieve success in 80% of those dogs that were considered poor responders by repeating the injection. So I think this is really good information. And you can establish your own cytokine protocol, but what we're advocating for is that at the first visit, you would give Cytopoint and definitely have them come back in 28 days. So in the 28 days, you're going to assess the response. If some dogs had a response that only lasted 2 or 3 weeks, you're going to recommend giving the second injection and have them come back in another 28 days. Now, if the dog is not itchy, he's a success, and theoretically he could come back when he started to itch again. But we're practicing in the time of COVID. We're trying to improve our efficiency, and we're trying to save our clients from having to run back and forth. So if it were me, I would go ahead and give that second injection and then say, now you can come back when your dog starts to itch. Now, personally, I think these dogs should have some Apoquel at home, because if they flare before they can get back, we want them to be comfortable. So, a small amount of Apoquel to have at home if they can't get in as soon as the dogs start to itch again. Now, again, if this dog became itchy before the 4 weeks were up, we'd give a third injection. And then after that, the dogs would get an injection as needed. So it's still a variable response, but what this tells us is if they have any response at all after the first injection, it's worth continuing with the Cytopoint. And this information is present in this clinical applications publication. This data will be published in a peer review literature sometime in the future. But for now, it is described in this clinical applications. And so this is an open access, and it's something that I can send after our meeting, and you can download it and have a look. Now, choosing between Apoquel and Cytopoint, I think it's really important to realize that these are two very different medications, and I don't consider them interchangeable. I believe that there are certain dogs that Apoquel is a great choice for, and certain dogs that Cytopoint is a great choice for. And for me, Apoquel is my medication of choice to control itch when I'm working a dog up. And why is that? Because I can get these dogs to stop itching usually within 4 hours of their first dose of Apoquel. So they're going to get comfortable quickly. This builds confidence with the client. And then if I want to see if an intervention is working, all I have to do is stop the Apoquel. It's got a short half-life. It's only 4 hours. So it is gone by 24 hours. So let's say I'm using Apoquel to do a food trial. I would do, feed that elimination diet for 8 weeks and use Apoquel to control the itch. And then sometime in 7 to 8 weeks, we would ask our clients to stop the Apoquel. If the itch comes back immediately, meaning within 24 to 48 hours, they're not food allergic. And then you can move on to the long-term management of atopic dermatitis. Apoquel has no impact on diagnostic tests, and we do have a long-term label. So if your clients are happy to give a medication once a day, then they can stay on Apoquel. But it is meant for dogs of at least 12 months of age. Apoquel is a pharmacologic agent, so we don't want to increase the dose and use it twice a day for long periods of time if we can help it, because that just increases the risk. Now, by contrast, Cytopoint is a biologic, and it has a lot of advantages, particularly for dogs who are difficult to pill or where owner compliance is a problem. I know I don't travel anymore, but I used to travel quite a bit. And so it's really nice to know that I can give my own dog Cytopoint and he'll be comfortable while I'm gone. You can use Cytopoint in dogs of any age. And so this was initially studied as a safety study in dogs of 8 weeks of age. I see plenty of itchy puppies. A lot of my atopics are even referred before a year of age. And so we can safely use Cytopoint in very young dogs and very old dogs and dogs that have comorbidities. So if a dog has a pneumonia, we can safely use Cytopoint. If you have referred a patient to an oncologist and they're utilizing a protocol, let's say for lymphoma, they're not going to want you to put Apoquel on top of that, but they will totally permit the use of Cytopoint. And another great use for me was when I was working with the internists, and they were managing patients with immune-mediated hemolytic anemia. And these dogs would be on prednisone and cyclosporin and azathioprine, and they were still itchy. So I could use Cytopoint to at least keep them comfortable. We all have a subset of patients that are and owners who do not want their dogs on long-term drug therapy. So Cytopoint, again, it's a biologic, it's not a drug. And I really like it for long-term management of atopic dermatitis. I think it's awesome for that purpose. And, when I'm managing a dog with allergy immunotherapy, I can use either of these medications. So they're complementary, but they're not really identical. And so how you choose will depend on the patient, the client, and your own feelings for what will work best for this patient. So it allows us as veterinarians to start to get into this personalized medicine concept. So Apoquel is meant to be used in dogs of 12 months of age. Now, you'll see on the label, it says it may increase the chance of developing serious infections and may cause existing parasitic skin infections or pre-existing cancers to get worse. That is on there not because there is data that proves that statement. It is a statement that the FDA once put on any drug that's classified as an immunomodulatory drug. So the happy news is that after 5 years of pharmacovigilance, where Zoetis got together with the FDA and they went over every adverse event that had been reported in. If you lump them all together, they're rare. And that means less than 1 to 10 in 10,000 doses. And so what that tells us is that's kind of like a vaccine reaction. So exceedingly safe. It's performing just as we would expect. So that makes me really happy because I do have patients who've been living on Apoquel now for 6 years. So here's where we're going to get a little interactive, and there's a couple of ways to enter this. One way is to download the app, use the Poll Everywhere app, and that's easy. When you would go into Poll Everywhere, you would be able to just type my name in, Valerie Fadock 074. It's not case sensitive, so that's not a problem. An easy way to do this, though, is to go to your text function, and you just, where you put the phone number, you put 22333, and then where you would put a message, you just type my name again, Valerie Fadock 074. And what should happen in a matter of seconds is that you receive a little gray box that says you've entered my session. So earlier today, we had really good participation. There were over 100 people who were participating in the Poll Everywhere. And so the data are really good. So please join. So just as a practice question, this is a word cloud. So using one word, type in your favorite atopic dog breed. Okay, we got one Westie. Frenchies, Boxers, Bulldogs, Aussie, Shar-Peis, Labs. None. Somebody doesn't like Westie. Somebody doesn't like atopic dermatitis. But you can see from the word cloud we're building here that there are a lot of dogs out there with atopic dermatitis. And some of these dogs, as you know, are extremely popular, like the Frenchies. Holy moly, they are just everybody wants a Frenchie. So I think, keeping in mind that this is a common disease and it starts in young dogs. Any dog with the name bull in its name, whether it's an English or a French bull, whether it's a pit bull, they're all prone to atopic disease. Smushy faced dogs like Shih Tzus and pugs and boxers, all of these dogs are prone. Little white dogs like Maltese and Bichon Frise, and retrievers and setters and terriers. There's just a lot. And depending on where you are in the country, you might see German Shepherds and Cockers as well. So this is a really common disease. And there's a lot that we can do to help these dogs that I didn't have available to me when I graduated. So these are all the dogs that I see too. Really a lot of fun. All right, let's start looking at some patients. So this is Ruby, and Ruby's pretty typical for a Texas atopic dog. She actually is a dog that was pulled from a shelter. We still have kill shelters here in Houston, and many of the rescue groups, the breed selective rescue groups, will go through and they'll pull dogs. Well, there's a lady here who just loves pit bulls, and she'll go through and pull them. If she thinks, she sees they have bad skin and she thinks it's Demodex, she'll bring them. So she looked at Ruby and said, oh, this dog's got Demodex. I can fix her and find her a new home. Now, before we move on to Ruby, though, let's review how we work up the itchy dog. And you've probably seen this bubble diagram. But in order for our Apoquel and Cytopoint to work optimally well, we really want to help the owner understand why their dog is itchy. Because if we don't do that, we're going to end up just dispensing medications in an intermittent fashion, and they're not going to have the deep understanding of their dog's disease that they need to have. So by doing the diagnostic workup, we are able to make the long-term management of atopic dermatitis as cost-effective as it could possibly be. So we focus on stopping the itch first. And for me, as I mentioned, for my workups, I think Apoquel is ideal. You could use Cytopoint for, those dogs that you're not comfortable using Apoquel in, but a diagnostic workup is just a lot easier to understand if you start with Apoquel. So we can start with Apoquel, and then we're going to rule out ectoparasites. We're going to treat and control infections. If dogs are non-seasonal itchers, we're going to conduct a food trial, and then we come to the diagnosis of atopic dermatitis. And this is where really good client education is critical, because these dogs will have atopic dermatitis for the rest of their life. It's very few dogs that grow out of this disease. And so we know that when we make this diagnosis, these dogs will be living on some type of medication to control their disease pretty much until the day they die. So let's come back to Ruby. She was pulled from that shelter, and the rescuer, she has quite a few dogs at her house, and so she's got a lot of Bravecto on hand. So she decided she's going to give Ruby a Bravecto and some cephalexin. And she did that, and yet it had minimal effect on her skin. Her itch level when I met her was an 8 out of 10. And I think you can see on her lateral stifle there, she's got really incredibly lichenified skin with crusting and erythema. She's got focal lesions of pyoderma on her abdomen and those focal patches of alopecia on her top line that her new owner misinterpreted as Demodex. That's quite classic for what we call short-haired dog pyoderma. So we've got this dog, failed to respond to Bravecto, failed to respond to cephalexin. Now she has, is coming to accept that maybe this is worse than curable Demodex, and she's heard about Cytopoint. She really wants to try Cytopoint. So you're already participating. I love that. And I honestly, like I say, I tend to start with Apoquel. Especially when dogs have a lot of inflammation, but I would have no hesitation in using Cytopoint for her as long as we get on top of that pyoderma. We have got to get that pyoderma under control, or Apoquel or Cytopoint are simply not going to work. And the reason they're not going to work is because bacteria and yeast, they induce cytokines that Apoquel was never meant to cover. It has to do with bacterial toxins and products. So we got to get that pyoderma under control. Now, at this point, do you think this dog has Demodex? I'm not going to argue with the maybes because this lady's got a lot of dogs. And, what if she gave Bravecto to Ruby without food and then Ruby vomited right after that? Maybe she didn't absorb it, and maybe she didn't know. So I think it's still possible. No one would ever fault you for doing some hair plucks to rule out Demodex. That's what we did, and we didn't find any. How will you treat the pyoderma? Ruby didn't respond to cephalexin, so what would your choice be? Use Convenia, switch to clindamycin, aggressive topical therapy, or take a sample for culture and sensitivity. So obviously, take a culture for culture and sensitivity is what all of us want to do all of the time. And her failure to respond to cephalexin suggests to me the possibility of methicillin resistance. Although I will say in my area, BID cephalexin simply is not resolving pyodermas like it used to. So there's still the possibility it's sensitive, but I would want to know. Well, the owner doesn't want to pay for a culture and sensitivity. So what's our next best step? We can use aggressive topical therapy because for the most part, it's a superficial infection, and we know we can resolve these infections with topical therapy. Now, our best evidence is for a veterinary chlorhexidine shampoo, somewhere between 2 and 4%. And one of the best studies that I've seen showed that if people will wash their dogs twice a week with a chlorhexidine shampoo and spray them in between with chlorhexidine, or you could use bleach or, you know, your favorite antiseptic, that we can resolve a superficial pyoderma. So I don't, you know, I don't honestly see a problem with trying Convenia. The one good thing about, well, there are many good things about Convenia, but if by chance Ruby didn't get all her pills because there's a lot of dogs and this lady struggles with daily medications, we know if we give Convenia, we're going to get it into this dog. And then we're going to do a 2-week recheck. And after that 2-week recheck, if we don't see at least 50% improvement, then we have to culture or go to aggressive topical therapy. And I would definitely couple my Convenia with topical therapy. Now, I wouldn't switch from a cephalosporin to clindamycin, but that's my bias. Where I practice here in the Houston area, our isolates are just not very sensitive to clindamycin. So in Houston, I only use clindamycin based on culture and sensitivity, but it could be different in your area. So Convenia, very, very safe. It's we know that even 10 years later, or more than 10 years later, that we're still getting dogs with superficial pyoderma, the most of them, 89% of them, to respond to one injection only. That's the reason for the 2-week recheck. We got to make sure we resolve that infection because there will be some dogs that might need a second injection. So here's some good news for Ruby. She responded really well to Cytopoint, and it worked really well for about 17 days. So her itch came back. And so what will we do? Well, I didn't have this information. So I ended up changing her medication to Apoquel and thought, well, maybe we'll use Apoquel for a while, and depending on how things go, maybe I could switch to Cytopoint in the future. You certainly could add some Apoquel onto the Cytopoint and use both. There are some dogs that need both medications, but let's try the second injection of Cytopoint. And that would have been great for Ruby. All right, here's Gavin. So Gavin, I don't know why I have female spayed. He's a male neutered American Pit Bull Terrier. And he's an atopic dog. He's been itchy most of his life. And actually, he's done quite well with Cytopoint. But the last injection didn't seem to work very well. And so the owner calls and says he's really itching his feet. You know, the rest of him's doing good, but he's itching his feet. So have a look at those feet. You can see he's got nice white nails. So we're looking up under the nail bed. We see a little brownish staining. We've got some staining on the dorsum, and the hair just doesn't look good. It looks like he's licking. So list one reason in your mind why Gavin is no longer responding to Cytopoint. System has adapted. Malassezia. Infection of some kind. Absolutely. This is what I would think of first. You know, think about infection, and especially for those nails with that brownish staining. It's not pathognomonic for Malassezia, but it is highly suggestive. So, you know, optimally, we would do a cytology and we would demonstrate the presence of yeast. And we'll talk a little bit more about yeast later. Demodex, absolutely. We don't have information at this point what he's taking. Could be staph under those nails. That's why we're going to do our cytology. Now, there are a few patients where we use Cytopoint over time and it seems to stop working. At least for me, most of the time, these dogs have a reason for it. It's usually my owners stop their flea control or the dog has bacterial or yeast infection. So the one thing to keep in mind about atopic dermatitis in dogs is that they can often develop an actual allergy to the yeast infection itself. And that means every time they have a yeast overgrowth that they will start to itch and they're going to break through their Apoquel or Cytopoint. So excellent, excellent suggestions here. So here's our cytology. We're going to get a little material from under that nail bed with a toothpick, or we're going to use a little bit of clear tape that we can kind of stick the edge up under there, and this is what we see. So yay, we have our diagnosis. So type in your diagnosis. You knew it already by looking at the feet, but it's always good to be able to document that. So now we've got to treat it. And, you know, this is a difficult area to manage topically. Some of my colleagues have advocated for getting something like Malice or your favorite shampoo and scrubbing the nails every day. But honestly, that might work for a very placid golden retriever. It's not going to work for most pit bulls that I've known. And so yeast really is a major reason for loss of efficacy. And if you're finding yeast under the nail bed, you're really going to need to put these dogs on a systemic antifungal. And if they have a history of repetitive yeast, we need to manage them long term. So you can use your azole of choice. It could be ketoconazole, it could be fluconazole, it could be itraconazole, or it could be terbinafine. So we use all of the azoles at the same dose, about 5 milligram per kilogram. And terbinafine, we have to use it at or 30 milligram per kilogram per day or more. And that's to allow it to get out to the skin to actually, you know, reach the yeast because they're surface. So if you're treating a dog with malassezia in the nail beds or really anywhere on the body more than once a year, those dogs are probably hypersensitive to the yeast. We know from studies done that virtually 99% of dogs with recurrent Malassezia otitis make IgE to the yeast, and dogs with recurrent Malassezia dermatitis over 90%. So you can be sure that if you're having to retreat all the time, you can take this pulse antifungal therapy approach. And when we do this, we take the same antifungal we use to resolve the infection, and we give it to the dog 2 or 3 days a week. I usually start with 2 days a week, and if that doesn't control things, we'll go to 3 days a week. And I've had Labradors and other atopic dogs living on ketoconazole twice a week for a decade, and they've had no liver enzyme problems referable to the ketoconazole. So this is a safe thing to do, and it often is the difference between success and failure when we're managing these dogs. So here's another example. This is one of my favorite patients, Dora. Dora was another dog who was doing great with her Cytopoint. She's actually a dog that I first started on Apoquel, but she was one of those who only did well on Apoquel if she took it twice a day. And so when Cytopoint came out, we jumped on Cytopoint. That was worked even better for her than Apoquel did. And so she would take it every 5 weeks. And, you know, for 10 months, she was doing great. But after the 11th injection, the owner called and said, man, it's only been a week and she's starting to be itchy. She's rubbing her muzzle and she's chewing her nails. So, you know, we would, in normal circumstances, she would come in and we would make cytologies and we would look. Now, finding yeast on a Yorkie is tough because they have a black nail. So you don't always see that brown staining, but if you look closely, you can see that there's a little exudate around the base of the nail. But we're in the time of COVID. So Dora and her mom are social distancing. Her mom is a high-risk patient, and she really is reluctant to bring Dora in. So that means no cytology. Now, we can do a telemedicine appointment with her. We know her, we have a valid client-patient relationship, and I know her history. So we know that she's had a yeast infection before. We can advocate for giving her fluconazole, which is what we did. And within 72 hours, she was right back in remission. And then after treating her with fluconazole for 2 to 3 weeks, we went to pulse therapy. And so she takes her fluconazole now every Saturday and Sunday, and now her Cytopoint injections last 8 weeks. So really think about the role of yeast in these patients. And just, you know, just for grins, what is your favorite oral antifungal? What do you like to use best? Yep, I like fluconazole an awful lot too. Really, any of the azoles, you can, the reason I like fluconazole a lot is that it comes in small tablet sizes. So if I'm treating yeast in a small dog or a cat, it's easy to use a 50 milligram tablet. And it is less likely to create a problem with upset stomach or liver problems than ketoconazole is. So that's why I like it. But it's a great medication, and this pulsing trick can be very effective for you. All right, if it's a telemed, so this actually is a Facebook consult, but I love this patient for so many reasons because this patient illustrates how our clients go everywhere else to get remedies first, and then they finally call us. And that's where we're going to lead with our best medicine so we get a success. So this is a dog called Tyson. You know, have a look at him. He's got a lot of erythema around his muzzle, and you can see these circular lesions on his neck. His entire ventral neck here is erythematous. And then look at his feet. You know, lots and lots of erythema there, but demarcated. So he's a rescue pitty. You first met him, let's say, about 6 months ago, and he was adopted when he was about a year of age, a little over a year of age. And he definitely had allergies and had a pyoderma at the time, and you effectively managed that. You gave him Apoquel and you treated his pyoderma with Convenia because it was generalized and bathing, and he did great. And he continued to do great over the last 6 months to a year. So you're a superstar, and the owner's super, super happy. But then he relapsed, and the owner called a report that he's bad. He's, you know, he's really chewing at his feet. He's really scratching in spite of continued Apoquel. So she tried to bathe it away, but it really didn't help that much. And she, of course, the first thing she did was post his pictures on Facebook to get some really good medical advice. And this is what Facebook came up with: CBD oil, aloe vera, Benadryl, topical chlorhexidine. That's not a bad thought, but she'd already tried that. A home-cooked diet, bitter apple. How mean is that, to make an itchy dog continue to itch but not want to lick because of a bitter taste? And an allergy to a flea medication, which is exceedingly rare. So look at the lesions again, you know, look at that erythema and the demarcation on the feet, and list a reason why you think Tyson is no longer responding to his Apoquel. Absolutely. That's my thought. Could be yeast. Man, yeast causes massive erythema. Could be staph. All of those things. And yeah, it is starting to look like a deep bacterial pyoderma. And you know what's interesting to me is, you know, most of the time with atopic dogs, compliance we always have to question compliance. I find that atopic pit bulls are more likely to develop deep pyodermas associated with their atopic disease than, you know, other breeds. Usually it's superficial pyoderma. So lots and lots of good choices there. So we'll move ahead. Now, if you were able to do diagnostics, let's say he came in as a curbside, what diagnostics would you want to do on this dog? What would be your derm database? Skin scrapings, absolutely. Scrape and tape, I like that. Ooh, I'm going to use that, scrape and tape. As an alternative to scraping, we can do hair plucks. We talked about them earlier today, especially on sore feet. You could take the hairs from the margin of that lesion with a hemostat and pluck them out and lay them in mineral oil, and it'll work really, really well. Tape preps, absolutely. These are all the things we would want to do if we see this dog. So all of these are great suggestions, and we might even need to consider the possibility of a fungal culture here, or even a bacterial culture. So yeah, these are all our derm tools that help us get to where we need to be. So if you couldn't do diagnostics, what would you recommend? Let's say that this is going to have to be a telemedicine appointment because the owner is at risk. Let's say that owner is immunosuppressed because they're being treated for an immunologic disorder. Let's say they're a human patient with pemphigus vulgaris and they're on a lot of immunosuppressives to control that disease. So they're not going anywhere. So if you couldn't do anything, what would you recommend? Absolutely. We're going to treat based on what we think it looks like, right? Normally, we want our diagnostics, but gosh, isoxazoline for sure. Could be Bravecto, could be Simparica, could be any of these great isoxazolines that we have. We could consider an antibiotic and an antifungal. We definitely want to do some bathing. So we've got some options. We absolutely have got some options. So if we look at, at least the way I'm thinking, I would do skin scrapings or hair plucks to look for Demodex. I do a cytology, and just as you suggested, depending on the cytology, I might want to do a culture and sensitivity. But if I couldn't do any diagnostics, I would totally put this dog on an isoxazoline because we know how effective they are against Demodectic mite. And I would be willing to wager my firstborn son, my only son, that dog has Demodex because of the way the lesions look to me. And then we're going to do some topical therapy. He likes baths, so she can be bathing his foot. Maybe we'll dispense an antibiotic. If you have an online pharmacy, you can dispense to her your favorite cephalosporin. If you can't give Convenia, I know I love cefpodoxime or Simplicef. I think that's a great antibiotic. So here's another patient. This is Simon. Simon's a cool dog. He looks like he's on drugs, but he's not. He's just one of these tongue out dogs. And he's about 7 years old. And he hasn't really had a lot of skin problems, but the owner called April of last year to her doctor and reported that he'd suddenly become itchy. So if you look at him, you can see he's got some hair loss around the eyes, maybe a little crusting. His belly isn't that red, but he's licking it because you can see all the matted hairs at the margins of that abdomen and perineal area. So these are his front limbs, so quite a bit of erythema that goes all the way up to the carpal area. And his elbow's got some erythema and some crusting, but his hind feet are really bad. These are the worst ones. These are the ones he's really chewing at the most. He's got a lot of crusting in this area. Very, very uncomfortable. So list 3 potential causes for sudden onset itch in Simon. Could be Sarcoptes, could be resistant bacteria. I'll tell you about his treatments in a minute. Yeah, we do see food allergy develop later on in life. You know, atopic dermatitis is a young dog disease often. Could be fleas. All of these things are possibilities. We can rank them as you see what he was actually treated with. So yeah, great suggestions. These are awesome. So we'll move on, and I can tell you that he received a Cytopoint injection and some Simplicef, and he did better, but then he relapsed. And he was really chewing at one of his feet, so the owner bandaged it, but she didn't get him into the doctor for about 4 days, so his foot kind of got macerated, and they cleaned it up and used Genesin spray, and they switched him to Apoquel. And then he had another flare, and he was treated with triamcinolone acetonide and more Simplicef, some topical therapy, continued the Apoquel, and he got better, but then he relapses again. So what the owner reports is he gets better, but he always flares up. And so this is a tough case. And you know, when it's just this difficult to control, I always come back to my, you know, my 4-step approach. Could it be ectoparasites? And one of the things I like about the idea of ectoparasites is the sudden onset of itch. Most allergies tend to be a little insidious. You know, I mean, if we have a food allergic dog who has a food indiscretion, we see a sudden flare, but often it takes a while for owners to recognize this, so we don't get this sudden call. He's gone from comfortable to, you know, totally uncomfortable. His only previous skin history was he developed a really mild dorsal pyoderma in the flea area that in fact was associated with fleas, and he was treated with ectoparasite control and some bathing, and that went away. So one of the things we need to know is she still using her ectoparasite control? And the answer would be no. Could it be a resistant infection? I mean, one of the things that wasn't clear is when he was on antibiotics, did all that crusting go away and then it came back, or did these lesions persist? Because if we made a cytology and there were cocci there, he could have a MRSP. Food allergy, the only thing that bothers me about this is the sudden onset. That's bothersome to me, because usually the first diagnosis, it takes a while. It's a little bit more insidious. And then again, most atopic dogs start when they're young dogs, so the sudden onset. So here's what we learned. His doctor had prescribed an isoxazoline, and the owner bought it, but we learned that they never gave it. And so we recommended, give that medication. It was Simparica, give him Simparica. And the owner gave the Simparica, and within a week, the dog quit itching. So scabies still on the table. And here's a beautiful skin scraping from Dr. Malden at UPenn, where she is able to demonstrate a mite there with the darker big arrow, and you can see some eggs, and those little brown dots are actually fecal pellets. And so if you find those on a skin scraping, that's a diagnosis. And so we have to consider, where do these mites come from? I think, you know, classic scabies in puppies are easy to diagnose. You know, they're classic. They've got crusts on their ear margins, and we scrape them, and so sometimes we find mites, sometimes we don't, but they respond to therapy. But older dogs, it can sometimes be hard to diagnose. So the common vectors are the raccoon, which is up there in the upper right. In the middle, we have the coyote. Well, they can be endemically infested, and boy, this one's got bad scabies, and I swear that's where the idea of the chupacabra came from. And then in the lower right, we have the red fox, and for us, when I was in Denver, they were the sources of our scabies mites that we saw. So this is just a case from Dr. Malden, you know, with this heavy crusting, and this dog had been treated with, you know, Cytopoint and Apoquel and steroids, and nothing was working. This dog actually has what we call Norwegian scabies, where the mites are, you find them, they're real easy to find, and the dogs get these heavy crusts. These dogs are incredibly contagious to others. So here's another example of a patient that I adore. I'm very fond of shepherds. They're goofy, and he's a typical goofy dog. He's kind of dramatic about things, but he's really fun. And when he finally grew into his adult body, he was a very, very beautiful shepherd. He was a gangly teenager, which is what you're seeing here. But when I met him, he was diagnosed at about a year of age. We worked him up for food allergy and atopic dermatitis, and he had both. In fact, most dogs with food allergy have atopic dermatitis. It's just food is one trigger. So we were managing him with immunotherapy, and we always advocate for ectoparasite control, but his owners forget. And so he will break with a pyoderma whenever he has a flea flare. And so they do use Apoquel to try to keep him comfortable. And they're calling to report that he has developed another pyoderma and their Apoquel isn't working anymore. Now, the thing about him is he's not one of these dogs that is that amenable to the way we practice in the time of COVID. He gets very nervous when he's away from his owner. And we have some options for him that, to reduce that fear. He could come in on trazodone, but this may end up being a telemedicine appointment. So these are some different ways to treat him, and I'd like you to rank your preferred choice. So we could give him trazodone and just examine him in the parking lot. I've done that quite a bit, where if a dog's too afraid to come into the clinic, I can go outside and do a derm exam. I could give him Convenia and recommend that they go back to their bathing program, and I could increase his Apoquel to twice a day. We could try to give him trazodone and walk him into the clinic without his owner. That could be somewhat trepidatious, but then we would be able to do all of the things that we want to do. We would be able to do our cytologies and do a really good job. And we could totally give him Cytopoint and continue the daily Apoquel or switch to Cytopoint. Or we could do a telemedicine appointment. This dog is a dog I've seen before. I know why he gets pyodermas. I know what they look like. I can tell them, let's, increase your bathing and bump your Apoquel up to twice a day. And if he's really struggling, he usually gets generalized, very itchy pyodermas. I could dispense Simplicef from my online pharmacy, and they would be able to treat him at home without having to come in. So lots of options for a dog like this, no wrong answers here. And as we know, cephalosporins work fast, and hypersensitivities are possible, but rare. So just as an example of what Convenia can do for this dog actually has had cephalexin in the past, and he's not an easy dog to pill. So one day he bit down on his cephalexin capsule, and that was the end of cephalexin for him. But we can utilize Convenia and get complete resolution in less than 2 weeks. So on the left, you see a quite inflammatory pyoderma. We've got papules and pustules. We've got epidermal collarettes. We've got crusting. But on the right, 12 days later after Convenia, we just have some post-inflammatory hyperpigmentation. So we're doing our 2-week recheck. To me, if there are no active lesions, no papules, no pustules, no epidermal collarettes, no crust, then you don't have to repeat the injection. It's the beauty of Convenia. It works very, very fast, and you don't get the up and downs that you get when we give an oral medication. So he's a good patient. I think we could do him either way, telemedicine or his curbside. All right, here's Little Pebbles. A lot of rescue dogs in my repertoire. I meet a lot of dogs that are rescues, and boy, these are the luckiest dogs in the world. So Pebble is a Spayed Maltese cross, and she was found as a stray. She actually was found as a stray in Las Vegas. So the thing to know about the high, dry Western states is they don't have the cat flea. When cat fleas are in Las Vegas, they come from California. You know, in Colorado, we used to blame the Texans. Same thing with Arizona. If it's really hot and dry, you don't have that cat flea as an endemic flea. There are plenty of other fleas. The plague fleas are there. But so this little dog, it lives in Las Vegas, and she was found on the street and was brought in, and she was taken to her vet. And you could see the only real lesion she has is that little area at the medial canthus of her right eye, and there's some crusting and erythema, and you know, maybe that's just tear staining, who knows. But she's not itchy, so keep in mind she's not an itchy dog, she just has that lesion. And so the problem was that they treated that topically with an antibiotic steroid ophthalmic ointment, which is a great choice for you know, infections close to the eye, but she had a more extensive flare. And this time the flare involved the muzzle and the forehead, and you can see the erythema there. So that was brought under control with, you know, some topical therapy, some antibiotics, and she did good. But then she had another flare, and this time it affected the back of her neck. And then the fourth flare involved the right rear paw. So the other feet were normal, but you can see the right rear leg has got erythema. It's got some ulceration that's kind of suggestive of pyoderma to me. So her cytology showed white blood cells and a cocci. And so she was treated with Convenia. She was treated with topical tacrolimus because her veterinarian was a little worried that that bright erythema on her face reflected something like discoid lupus. And so she would initially respond to therapy, and then she would relapse. And so here's where her doctor biopsied her. So what clinical features on this dog give you hints about the diagnosis? What about this case makes you think of any one thing in particular? She's not itchy. So, you know, using Apoquel and Cytopoint are not, you know, not indicated here because she's not an itchy dog. She might well have an immunologic disorder, and that's why her doctor did the biopsy. She wanted to know. It keeps coming back. So clearly there's something else going on in this little dog. So the one clinical feature that I find very telling is asymmetry. You know, most of the skin diseases we see, whether they're allergic or immunological, they tend to be very symmetrical. And so this dog has asymmetry. And so when I think of asymmetry in dogs, I think of two things. I think of dematicosis and I think of dermatophytosis. So these are the things I'm considering. You know, the asymmetry suggests to me what Danny Scott used to call big D and little d. Little d is dermatophytosis. So it turns out that the biopsy revealed dematicosis. Now, the one, you know, the only minor criticism I would have of the workup of this dog is I don't think skin scrapings or hair plucks were ever done. And I might not have done one with the first lesion, but I want to come back to her face and just show you the thing that makes me much less likely to think this dog has an immunologic disease. So even though she's got erythema that is on the, you know, the dorsal nasal area, see how her planum nasale is spared. So erythema and maybe even some crusting that comes right up to the nose, but it doesn't invade that nasal planum. Most immunologic disorders that affect the face are going to cause graying or loss of pigmentation in the nose. Oops, what's going on here? All right. So easy, easy, easy. We got this. So you said this to some extent, but what is your favorite way to treat dematicosis these days? Isoxazoline. Man, I can tell you, when I graduated, I never thought that I would see the day where I would give an oral tablet to a dog and be able to treat dematicosis. Just amazing. So you should be aware, you know, we have 4 different isoxazolines Vaselines in the United States. It is considered off-label to use them for demodicosis, but it's the standard of care. If you use Bravecto, I would highly recommend that you give it with food. You won't get the good absorption unless it's given with food. Also, it's important to give Credelio with food. So those two brands must be given with food. Neither Simparica or Simparica Trio or NexGard need to be given with food. So in fact, that's why I prefer them, because I struggled so much with my clients with Trifexis and Comfortis. So keep in mind, Bravecto and Credelio need to be given with a meal. And here's just another Las Vegas dog, kind of the same story, only with a deep pyoderma. And this reminds me, again, when you see a Shih Tzu who starts life with allergy, but then develops deep pyodermas of the feet, it's Demodex until proven otherwise. And I'll just show you some of the lesions. We can see alopecia and hyperpigmentation. The tail is twice as thick as it should be. It's full of pus. And so when we do our hair plucks, we see beautiful mites and even an egg in there. But if you did cytology from exudation, sometimes you'll see the ghost of the mites right in the cytology. And so you know what you're dealing with right then. Our impression smear of this dog, this was an ongoing pyoderma and it's deep, so we had a lot of macrophages in there, and there's a big old fat macrophage full of cocci, and there were rods in there too. So I might have time to do one more patient set with you. Would you rather look at Vader on the left, who is, and you don't have to type it in, well, actually you do need to type it in the chat pod. Maybe I put it here. Yeah, no. What would you rather see? Would you like to switch to cats for the last couple of minutes before we start questions, or would you like to do another canine patient? We've looked at a shepherd already, so if you want to do cats, I'm always game.
It looks like cats is the preference.
All right, let's do it. Cats. Wow. Poor cats, right? Now we've got all this like cool new stuff for dogs, and poor cats got nothing. Although, you know, I'm happy to report to you, Zoetis is really interested in feline allergy and equine allergy, so things are in the works. But you know, when I look at the itchy cat, I'm going to do the same workup for them that I'm going to do for a dog. I'm going to control the itch. I'm usually going to use a short-acting oral glucocorticoid to do that. And then I'm going to look at ectoparasites. I'm going to look at infection control, and I do cytologies in cats. I don't think they get pyoderma as frequently, but they do, and they get malassezia. So cytologies are good. If they're non-seasonal itchers, we will attempt to do a food trial, and then they get atopy. And just like dogs can do very well on allergy immunotherapy, so can cats. And so if you're interested in allergy, I can share with you that allergy immunotherapy based on serum testing is just as effective as allergy immunotherapy based on intradermal testing, at least if you compare populations. So we're going to start with this kitty. Diablo is a kitty that I met actually many years ago. But I learned a lot from this kitty. So when I met him, he had severe pruritus, as only a cat can have. You know, they can literally deglove their heads when they're super itchy. So you could see he's got a lot of alopecia and crusting on his head. And this is his shaved side. And what you could see is that these are miliary dermatitis lesions, but they're very, very crusted and really quite severe. The purple dots you see are the results of an intradermal test, which was quite a challenge because he hardly has any normal skin, but we did it. And because the intradermal test was negative and this was so severe, I did decide to do a biopsy, because look at how crusted his head is. You know, sometimes we see cats with pemphigus foliaceus that look a lot like miliary dermatitis. So he's had a 2-year history of progressively increasing itch. It's a non-seasonal itch. He's mostly indoor, but he has, you know, the Florida version of a catio, which is a screened-in lanai. Flea control, actually, they did good flea control on him, and it didn't seem to help much. And no fleas were found on our exam, but I would never rule out fleas based on not finding them. We know that cats groom them off. And he was initially responsive to Depomedrol, but had become refractory. And to me, this is quite common in cats. They can do quite well the first year with Depomedrol, but then as the years go on, they need the injection more frequently, and we get into increased risk, especially of diabetes. So his workup, skin scraping's negative. I biopsied him because I was worried about pemphigus foliaceus, but the biopsy showed an eosinophilic dermatitis comparable with a hypersensitivity. So we recommended a diet trial, and lo and behold, these people were actually willing to do it. And at that time, lamb and rice was a good choice. Now, of course, it's not, but they were willing to do a home cooked diet for him and feed that for the next 6 to 8 weeks. And so lamb and rice is no longer a good choice for a diet trial. So what do you recommend for cats? And I'm going to type in what I recommend. Yeah, we've got some good choices here. It's nice to know that Ultimino is available for kitties, so if they will eat it, this is a word cloud, so my words will be broken up, but I just put in what they will eat because I may want a cat to eat something particular, but they will turn their nose up to it. So what we used to do is we kept a small amount of food in our practice, and we would send home 3 or 4 baggies of food that different types. You know, we would do ZD, and we would do rabbit, and maybe venison, and now feline Ultimino, and we would have the owner feed that as a smorgasbord, and then the food the cat would eat is the one we use for the diet trial. And so most dermatologists are advocating for hydrolyzed diets now because we have no novel proteins. Everything we've ever used is over the counter now. So just to move forward with my friend here, we'll just skip this. I mean, Depomedrol isn't working. So what dermatologists will often do is switch these cats to a more potent steroid, at least initially. I like oral triamcinolone. Some of my colleagues prefer oral dexamethasone. That's not meant for long-term use. It's just meant to cut the itch at the front end of the food trial. But look at how good he looks 6 weeks later. So this was an owner who was willing to do challenges, not reactive to chicken, not reactive to milk, really reactive to beef. He's really beef allergic. We used, at this time, a little oral methylprednisolone to quiet it down. Soy, no problem. I don't even know why I did soy because most cat foods don't have it. Fish added, no response. So all they had to do was feed him a beef-free diet. And so he was one of the few patients I had that truly seemed to be all food allergic. And so here's another example of a cat, you know, head and neck pruritus that responded to Royal Canin rabbit and pea, normal in 6 weeks. And this is a fish allergic cat. So, you know, I use the same workup for cats. The medications I use are going to be different. Here's an example of an atopic cat. This is Snowflake, and Snowflake is an over-groomer. So the first thing I have to rule out is flea allergy and the possibility of Demodex gatoi. And the nice thing is you can do that with Revolution Plus or topical Bravecto. Isoxazolines will kill that mite. But this cat ended up to be an atopic, and we were able to put her on allergy immunotherapy. We actually used sublingual drops, and she did great. So the syndromes we see in cats with itchy skin or allergic skin, over-grooming, miliary dermatitis, eosinophilic granuloma complex, and head and neck pruritus. And then some cats that get that weird ulcerative dermatosis between their shoulder blades, they can have allergies. It's a syndrome. So, you know, there are other causes. And then what we used to call idiopathic facial dermatitis of the Persian and Himalayan, that's often full dermatitis associated with a hypersensitivity to yeast. So I'm going to stop there. So we've got a little bit of time for questions, because I know it's getting late for you guys, and you probably have to get up early and go to work. So feel free to ask any questions, and I'm going to prepare a PDF of the slides we showed tonight and a hyperlink document to some interesting papers for you. And I guess they'll be posted up on your website and you'll be able to download them.
Okay, Valerie, I'm going to go over the questions, and I would say we have quite a few. We're probably not going to be able to get to all of them tonight, so keep within the time. So what I would ask is, if possible, some of them I think can be answered pretty quickly, and I'll try to group some. The first one is, when you say pulse therapy relating to, you know, antifungals, do you give it 2 to 3 days in a row, or 2 days spread out in the week? So like maybe like a Tuesday, a Friday, or do you do, you know, you had mentioned before Saturday, Sunday. What do you mean by that?
Right. I mean, for my own sense of symmetry, I would prefer a Tuesday and a Friday, or a Monday and a Thursday. But if owners can only remember to do it on the weekend, 2 days in a row seems to work just fine.
Okay, thank you. And then somebody also mentioned pulse antifungals, or are you using, fluconazole orally or injectable?
Oral. This is all oral therapy.
Okay. And then I've heard Convenia may not have consistent blood levels. Do you want to comment on that?
Sure. You know, Convenia really is meant for skin and soft tissue, and the levels in the tissue are higher than they actually are in the blood levels. So the blood levels of Convenia don't mean much for us in dermatology, because we're not treating a blood infection. But we know from tissue cage studies that the levels in the skin are very high quickly, and they persist in the skin in dogs for anywhere from 14 to 19 days. So that's probably why one injection works so effectively. So the blood levels for skin, at least, are not important when we're using Convenia.
Thank you. And then a few questions around the Cytopoint, you know, first, second, and third dosing study. The first one was, so if you're doing that and you have like a breakthrough, say, you know, you don't make it to the end of the month, is it okay to give that second dose at like 14 days or 21 days as opposed to 28 days?
I believe it absolutely is. You know, technically we would call that off-label, but that's what most dermatologists do. The alternative to that is, you know, to make sure that they have Apoquel at home. They could use Apoquel until day 28, but you know, there's no safety issues with giving it earlier than 4 weeks. It's just not on the label.
And then with the Cytopoint study as well, do you have any information on whether the dogs that were, you know, not doing well after the first injection were at the upper end of the weight range for a given dose?
That's an interesting question, and I honestly don't know that. Hopefully that will come through when the paper is published. But one thing I can tell you, a lot of my colleagues tell me they think larger dogs do better with Cytopoint than smaller dogs, and most of us tend to dose up. So I have a 23-pound Frenchie. Technically, I could give him 20 milligrams, although that's slightly less than 2 milligrams per kilogram, but I give him 30 milligrams. And so I would use 2 milligrams per kilogram as your absolute minimum dose. And if you're giving more than that, that's okay, because it is safe to do so. And we advocate for giving a minimum of 2 milligrams per kilogram. So, you know, it's possible, you know, we'll look at the data for these studies. I think the dogs are dosed quite precisely. So if they are, you know, if they need like a vial and a half, they get a vial and a half. and the rest of the vial gets thrown away, which just makes my heart hurt. But you know, they're trying to be quite accurate with the dosing, so no harm in dosing up, and hopefully that information will be revealed in the paper.
Thank you. And then Valerie, as far as using Apoquel, do you have like a preference as far as doing the full, you know, twice a day for 14 days to start with, or how do you decide how you're going to start dosing?
It's really based on the dog. And so the beautiful thing about Apoquel is you have so much flexibility. You do not have to give it BID for 14 days. If you have a dog, let's say that's moderately itchy, you could just start even with once a day. You know, give it in the evening, and everybody will sleep through the night, and dogs will do well. You can use it twice a day for a shorter period of time. I tend to use it twice a day in my food allergic pets when I'm starting a food trial. So I'll give it BID sometimes for the full 14 days because those dogs are really itchy, but then I drop it down, and you know, they've been on their elimination diet for a couple of weeks, so you know, I don't get I rarely got that rebound effect that we talk about. So no, you don't have to do that. And I gauge it on the severity of the itch. So if I'm dealing with a patient who's so itchy, he's itching in front of me in the exam room, that's probably going to be a BID dog, but maybe not for 2 weeks, maybe for 5 days or 7 days.
Okay. And then just to clarify, you don't have to give Simparica with food, unlike some of the other isoxazolines. And if a dog is on Simparica correctly, Demodex would probably go a lot lower on the differential list.
Exactly. That's exactly the way I feel. We know from the work that was done that neither NexGard nor Simparica require food. The blood levels are the same regardless of whether food is present or not. By contrast, if you pull the pharmacology papers on Bravecto and Credelio, you'll see there's a huge difference in the absorption and blood levels when it's not given with food. Now, if you want to give it with food, you can. You know, most dogs, at least my dogs, they'll take Simparica like crazy, but you know, some dogs are suspicious. And so you can always wrap it up with food, but you don't have to.
Okay. And then a few people are asking comments about the use of Apoquel in cats.
Sure. Apoquel in cats, as you know, is an off-label use, but we now have several papers in the literature that document the use of Apoquel in cats. So what I have to tell you is the half-life in cats is very short. The half-life of Apoquel in cats is 1 hour. Compared to 4 hours for the dog. And so what that means is they may require it more frequently. So the way dermatologists get around that, and this is in the literature, we give double the dog dose when we give it. So, you know, usually 1 milligram to 1.2 milligram per kilogram twice a day for 14 days. And then I try to drop it down to once a day. You know, most of my derm patients can drop down to once a day at that high dose. Some of them may need that high dose twice a day. And so that very short half-life is why, you know, Apoquel has not seen approval yet for cats. It's possible that the R&D guys are working on this. They don't tell us anything until they're ready to go, but you know, they're very interested in working on a feline version of Cytopoint, and maybe in the future we'll see Apoquel actually approved for cats. So I don't use it as my first choice. You know, most of the cats I put on Apoquel were cats who failed to respond to ATOPIC and had become refractory to steroids, or they were becoming diabetic and we couldn't use steroids. The one thing I can tell you is it's not as predictable. I mean, we can predict that most dogs are going to do really well with Apoquel. We're not, you know, it's not as predictable in cats, but there is a study that compares it to the use of oral prednisolone in cats, and the data, you know, the itch relief and the reduction in lesions in the skin is very comparable to prednisolone. So I think if you have a need for it, even though it's off label, you can justify using it. Just have a conversation. Well, most cat owners know about off label because we do a lot of off label things in cats, but they just need to be aware that it's an off label use.
And then following up on that, I think you kind of commented on this, but what's your preferred recommendation for an itchy cat?
So usually I'm going to work them up just as we talked about. For the short term, I still like, to use my steroids because they're we've used them for years and Apoquel isn't approved. So I'm going to use my steroids. I don't like to use steroids for long-term maintenance though. So if I'm going to if I have an atopic cat that needs long-term maintenance, I'm usually going to try feline atopica. But I do a lot of immunotherapy in cats, and most of it after a while got based on serum testing because although I've done a lot of skin testing in cats, it's quite hard on them. They have to be sedated, and the tests are hard to read, and it's a different test from a dog intradermal test or a horse intradermal test. So just easier to get the serum, send it in. Cats, most cat owners, prefer to give injections. So it's real easy to teach people how to give these injections, and cats can do really well with allergy immunotherapy. So, if they need a long-term medication, I'm really trying to go for Atopica. Doesn't work for all cats, but if I can't, if I can't use steroids and Atopica doesn't work, then I totally bring up a conversation about Apoquel.
Thank you. And then a question about serum allergy testing. They weren't sure if they heard that serum allergy testing is now as effective as intradermal testing. They've always learned that serum is not as reliable. Can you just comment on that?
Right. And, when serum testing first came out, it was really poor quality. And so it was very easy for all of us as dermatologists to say, this is not going to help you. But the companies have made great advancements. Now, part of the problem in our interpretation in the old days had to do with we wanted the results of a serum test to be identical to an intradermal test, and that rarely happens. I mean, you get some overlap, but it's rarely identical. So the best way to look at this is response to therapy. And we have at least 5 papers for dogs that show response to allergy immunotherapy is the same based on serum testing or intradermal testing, at least if you look at populations of dogs. We have that same data for horses, and there might be one paper for cats as well. So most of the success of allergy immunotherapy has to do with managing expectations in the client. It's an investment in the pet's future. So it's not going to work today or tomorrow, and we have to control the itch. So I tell them, in a year, we'll decide if your immunotherapy is effective. But right now, for dogs, we got Apoquel, and we've got a Cytopoint. We'll keep your dog comfortable until we can tell if this is working. And for cats, we can utilize glucocorticoids. Usually cats on immunotherapy, we can reduce their glucocorticoids pretty quickly. We can use Atopica. Often when they're on immunotherapy in the early days, we can get the Atopica down to twice a week, which is great, and then eventually phase it out. So that's kind of my approach.
Thank you. And we'll do 2 more questions because I know we're a little bit over already. The first one is with these available, I assume they're talking about Apoquel and Cytopoint. Are there any instances in which you would still use prednisone or pred or cyclosporine instead?
There are circumstances in which we absolutely have to use the glucocorticoids. So as an example, sometimes when we meet bulldogs, they have horrible interdigital cysts and their ears are swollen shut. And I know I can't open those ears up with Apoquel or Cytopoint. So I will utilize glucocorticoids initially to open the ear up, to get the infection under control, to get those interdigital cysts resolved. We work the dog up, and then I can transition that dog to Apoquel or Cytopoint or whatever we all think is going to be best for that individual patient. So if an ear is swollen shut, or they have interdigital cysts, you need some steroids for those animals to get the initial disease under control. Now, there are a few dogs out there who simply do not respond to either Apoquel or Cytopoint. They're very low in number. And so if the owner is willing to try Atopica or a bioequivalent, I'm happy to use cyclosporin in those dogs, but it doesn't work as fast. And honestly, my experience with cyclosporin in dogs is that unless I'm doing immunotherapy too, I can rarely get them to less than once a day. So if we're using Atopica brand, that's expensive to use on a daily basis. If I'm using it with immunotherapy, I can usually, reduce it to 2 or 3 days a week, and then it becomes a little bit more affordable. So yes, there are still going to be uses for Atopica. One of my favorite was an atopic shepherd with perianal fistula. Apoquel doesn't work, at least based on the one case I tried. So that dog's great. Atopica will control the perianal fistula as well as the atopic disease. And then there's an even smaller subset of dogs that don't even respond to Atopica. And those are the dogs that may have to live on steroids long term. And that's when we pull out our old safe steroid dosing, where we calculate the amount of steroid per year that they can have. And we divide that up into an alternate day dose, and we hope that we can stay there to keep them comfortable. And that's where Temerol P was, a lifesaver for us. So there are going to be some instances where, neither Apoquel nor Cytopoint work, but I think they're rare, especially if we do all the other things, the isoxazolines and good infection control for these dogs.
Okay. And do you have a best treatment for over grooming in cats?
My first thing is treat them like an allergic cat. And so the first thing I'm going to do is put them on, my choice, of course, would be Revolution Plus. So I'm going to do a Revolution Plus trial because I think as a profession, we underestimate the prevalence of Demodex gattii. It is not just a southern disease. It's in Colorado. The best papers on it come out of Finland. There's nothing tropical about Finland. And I think the reason we don't recognize it is because it's so hard to find on skin scrapings. So I would totally do Revolution Plus first. And then after that, our choices in the absence of infection, we need to rule out other medical causes. So, we're going to consider things like a food trial and atopy. Maybe there's a different medical cause. One of my favorite hair pulling kitties was a kitty who had urinary cystitis. And every time the cystitis would flare, this kitty would pull all the hair out of her abdomen. And then we would treat the cystitis and all the hair would grow back. If they're if they're over grooming over joints, we have to think about arthritis. We're learning a lot more about arthritis in kitties now. And sometimes, over grooming is a manifestation of pain rather than itch. So all of the studies that have been done tell us that while behavioral causes are possible, they're not common. So diagnosing a behavioral disorder as a cause for over grooming is kind of a diagnosis of exclusion in itself. And so we would go through our medical workup, and then if we end up with behavioral, then the behaviorists recommend you could use some mood modifying drugs, but you really need behavioral interventions, training techniques that help to focus the cat on different things. I don't think I could do it. I'm a terrible dog trainer. I don't know how I would train a kid. I'm just not a good trainer, you know, but there are people out there who are really good at this stuff. But behavioral as an exclusive cause of over grooming is not common.
Okay, thank you. And then do you have where do they get the year dose calculation for steroids?
I will put that formula in my PDF that I make for you. I will add for that, and I'll give you the reference for it. It was when Candace Souza, who used to work for Zoetis but is now retired, she was the queen of Temeral P. And so I'll give you the whole calculation and give you some examples of how we used it. And, you know, it doesn't mean that that's all we use, but we know if we're having to use above that dose frequently, we gotta try something else. So I'm happy to provide you that. It'll be part of the handout.
Okay. And is there a recommendation? I would promise, Dr. Sadek, we're getting towards the end. Is there a recommendation for controlling severe atopy in a breeding dog while pregnant and lactating?
Ouch. You know, to my knowledge, there's nothing approved for these dogs. And the only thing that I could suggest, we know that tepid baths with moisturizing shampoos can soothe the skin temporarily. And so we would advocate it would have to be daily, maybe using cooling sprays on the skin. One of my colleagues that are my classmates that works in Hawaii, he mixes up vinegar and water, and he will use that to soothe the skin. He keeps it in the freezer. You know, the interesting thing about bleach, we use bleach to kill resistant staph, but actually dilute bleach has some anti-inflammatory activity. So people could put dilute bleach in a sprayer, and I'll give you the formulas in the handout as well. Dilute bleach and spray, but it's not going to work like our medications work. But we, you know, neither Apoquel nor Cytopoint nor Atopica have been studied in pregnant dogs, and we just don't know what the outcome would be. And if, I mean, you know, one thing we could say is, do you really want to be breeding an atopic dog? But it's a complicated disease, and you know, there's so many genes involved that we'll never breed it out of the world. It's best to control the environmental triggers. So the only thing I can think of is bathing.
Thank you. And the last question we'll address tonight, and thank you everybody for the questions that you've sent in. Any that we haven't gotten to, Claire will get you some information if you still want to ask them, so we can make sure we reach out to everybody, because we want to be respectful of everyone's time tonight. Does Revolution also treat Demodex, or only Revolution Plus?
Only Revolution Plus. It's really the Cereloner in there that's killing the Demodex mites. Legacy Revolution, selamectin just is not effective. It's the only thing, you know, that it wasn't good for. You know, it was good for so many things. But adding the Cereloner Revolution Plus just gives it that extra oomph. You know, we're killing fleas faster, and you know, controlling ticks on kitties. And so, yeah, unfortunately, no, old Revolution doesn't kill Demodex.
Thank you.
Well, great. Thanks, everybody.
All right. Well, we did pretty well. We went just a little bit over. We have a little over 100 people still on right now, but really thank everybody for joining us tonight, and thank you, Dr. Fadek, most of all, and Dr. Jerkson for helping us put this seminar on. This is always a very popular topic, so it's really nice to have this information during derm season especially. So hope you guys have a wonderful evening. The recording of this will come to you with your CE certificate afterwards. You'll get a link directly to the recording. It'll also be posted on thrivevet.com/learning. As far as the materials, all of you that attended tonight, I'll just send an email directly after we have them. But they'll be hyperlinked right underneath that recording as well once it's on our site, so that there's the reference of the written with the video there. So thanks very much for being here, and we look forward to seeing you guys again in the future. Hope you have a wonderful evening.
Good night.
Good night.